And as you can imagine, studying infectious diseases, we pivoted quite sharply to examining COVID last year. And our team's work is primarily among three groups of people: sex workers, Black, cisgender, gay, and bisexual men, and transgender and gender diverse people, particularly transgender women of color. And the reason we study these three groups of people or work to do research with them is because you can imagine, particularly in the United States, although not exclusively, I know to a lesser extent in the UK as well, these groups experience what we often refer to in public health as health disparities. So basically lower access to care, lower health metrics, however you might measure them. And the very striking and admittedly incredibly sad thing that we've been observing with these groups over the past year is just how powerfully COVID-19 has activated the same kinds of health disparities that we are used to seeing with HIV. So Black and African American people in the United States, for example, have been getting COVID at much higher rates than their white peers, dying from it at much higher rates than their white peers. And now, as the government shifts to implement a vaccine program, rather distressingly, despite the truth of those earlier figures, vaccine uptake rates are highest among wealthy white people. And to me, this really kind of highlights, I mean, there's been a lot of talk and a lot of writing around why or how HIV and COVID-19 are similar as well as how they are different. And we've been using some of that work to guide our own research. So, you know, one of the cool things about HIV is it's the most studied virus ever in human history, right? And we built whole new systems of science and whole new ways of doing research around this particular virus, which we could then deploy relative to COVID-19. And I know many of us have in many different ways. But one of the distinct differences about it, although HIV definitely has a class component and a racial component to the people it infects and the way in which mortality is produced through it, it really pales in comparison to how we think about COVID-19. So the people most at risk for COVID-19 are people who are poor and people of color, without question. And this is consistently found around the world, especially in the United States, but also I know in the UK. And this is what I mean about health disparities. Those things were true or are true for HIV as well, but really to a much different kind of degree. And because of the unique transmission dynamics of HIV, you also implicated this huge group of relatively privileged white cisgender gay men, which is not what we've been seeing with the COVID-19 pandemic. So these are kind of, in my mind, the two major differentiating factors. But anyway, I'm kind of rambling here. I'm kind of going off on a few different tangents, but these are certainly some of the things that have been on our mind and we're using to shape our research going forward. The challenge has been how you get governments and funding bodies to care about the poor and disenfranchised. It has been difficult, for sure, as is evident in the way the vaccines have been rolled out here. And I'm really excited to hear, I know that our governments have both abandoned us in sort of different ways. So I'll be curious to hear about the UK and the perspective from all of you about how things are going in that space. But from my end, I'm trying to focus less on the way in which these different epidemics or pandemics, the way in which they're different, and more about how the lessons we've learned from HIV can be applied in this new era. And the most important one that's been guiding our work is engage with the communities that you want to support, talk to and form coalitions with the groups that are already doing this work on the ground. And so I'm really excited that we have been able to do that thus far with a diverse collection of trans health advocacy groups, sex worker advocacy groups, and groups that support the health of Black, gay, and bisexual men. Because it's with those networks that real change, I think, can be achieved. So that's my very high-level summary. Of course, I'm happy to answer any questions, and thanks.
And introduce our next speaker, which is Jack Lopez from the University of Bradford.
Okay, thanks, Matty. Evening, everyone. Can you all hear me okay? Because I've got sick of putting things in my ears, so I'm just going freestyle at the minute. Yeah, I think there's some comparisons there, but some things that I think are slightly different, really. I suppose when I think of the perspective that I come from, I come from as my previous life as a social worker with a sexual health background. I mainly worked with HIV, with sex workers in the UK many years ago, but I worked in Mexico for 8 years, and continue to work on HIV and AIDS in Mexico as well, in the southeast of Mexico. But kind of thinking about in the context of my research at the minute, since God, I can't measure time anymore in lockdown. Sometime in the past, no, it was around about June, I think, 2020. I started to research with the trans and non-binary communities around the UK, in terms of because my focus in all of my research is on barriers to healthcare, regardless of working with different marginalised groups, but because coming from personal experience and just from being around different communities, I've been spending the last 8 or 9 months or so carrying out interviews with people who are receiving transition related healthcare. So it's trans and non-binary people who are in the public health system already, or they're in the private health system, because my main interest isn't necessarily about what COVID is doing as a disease. It's about the impacts, the social impacts. As an anthropologist and a medical anthropologist, I want to know what else it's impacting on in terms of people's lives. And the main issue that we have here in the UK in terms of trans and non-binary people is that they are already very much involved in a broken health system. So they're in the worst of the worst forms of our public health system. There's barely anything, you know. So whether you know anything or a little bit about gender identity healthcare in the UK, the one thing you probably do know about it is that we have humongous waiting lists. We have a lot of gatekeeping. It's almost impossible to get what you need. It is a health system works from a standpoint of doubt, where whether you're a child, a young person or an adult, you have to prove yourself and beg for healthcare essentially. And the timeline can be anything from 2 to 10 years. Essentially, as you go through the public health system. It's very set up as a binary, so essentially they want you to go in as one gender and want to be only another gender. There's no in between. If you say you are gender fluid or non-binary, they'll push you out the door. It's difficult. So people who are already marginalised, people who are already, you know, involved in areas of sex work, are heavily unemployed, have other health issues going on. What happens then when an epidemic then becomes a pandemic, hits a country and the health service shuts down? So that's what I've been kind of researching over the last year. So aside from levels of isolation, so the trans community is heavily involved on being together as much as the wider LGBT community are. It's community. People need each other. So there's been an element of complete isolation, especially of people that live in rural areas who have to travel very far for their healthcare, because all healthcare is based in the cities. There are only 7 gender identity clinics for adults in the whole of the UK. People from Northern Ireland have to come to England. People from Wales have to. There's isolation. There are a lot of younger trans and non-binary people had to go back and live at home with families who don't support them, who don't recognise who they are. A lot of people stuck in abusive relationships. We know across the board that domestic violence went up through COVID. So it's really, for me, is looking at not, you know, the people, trans people and non-binary are not more affected by COVID than anybody else, you know, unless they're already intersected with another minority group to do with their ethnicity or their race. But it's actually what the wider impact of a pandemic does on people who are holding onto the shoestrings of an already broken health system. People couldn't get hold of hormones in the first few weeks. People who have been waiting 5 to 6 years for surgery, who were just about to go into the theatre when the pandemic hit, are still now kind of, basically people have been left in stasis. Nobody knows when they're going to be able to have surgery again, which impacts on people's lives, their quality of life, their ability to work. So one of the things that I've been looking at a lot in my research is the lack of communication between public healthcare systems and patients. There has been no communication between patients and gender clinics. The doors shut and that's it. So people's the levels of anxiety and mental health issues have really gone through the roof, which is something that I've seen. However, on the flip side, the reliance that the community already has, especially people that live outside of cities, on the internet and online support, has actually really helped people and has been an increase. And the information, which is problematic when we look at misinformation, but the way that the information has got around is that actually the trans community are supporting each other. You know, there are insiders who work in gender clinics, who work in the health system, and they will feed information out into private groups online, and that is how people are getting the information they need about their health. So there's a lot of underground systems going on, a lot of information being spread around. And I think when we look at the comparisons to the HIV epidemic of the 1980s particularly, there are some comparisons there in terms of a community being abandoned and having to fend for itself in terms of finding information, whilst at the same time being around a situation where, you know, where people are losing their lives in a pandemic, but trans people, and particularly trans young people, are losing their lives through suicide in a pandemic because they're being abandoned. I'm doing a talk in Bradford for Bradford Council last night, and there was discussion of a young person who recently took their life the other week for similar issues with not being able to get the services they need. So I think it's a really tricky question to ask about how we make these comparisons, because on one hand, and I don't know what Denton and Billy would say about this, there's no comparison at all. And then on the other hand, there are. And I think the comparisons are the social comparisons. I think, you know, what's already been said is the one thing that the pandemic has brought out, which is comparable to what went on with HIV in the 1980s, is that the way we marginalised communities are immediately affected and hidden and shut out of health services, and communities that aren't necessarily represented on this panel today, you know, without making assumptions, because I don't know about people's personal lives, but, you know, in terms of precarious workers, illegal grey economies, sex workers, undocumented migrants, low-paid healthcare workers, Black, Indigenous, persons of colour, people with disabilities, any intersection of those things, people who also, ironically enough, were quite missing from the thin cast as well. You know, we generally had a cast of cis gay men with one female straight friend. The only lesbian had a name, but she never said anything. So it's kind of, yeah, but I think that's kind of typical of Russell T Davies's work as you go through it. It has, coming from my global health background, it's definitely recreates this global discourse of the deserved and the undeserved in terms of who's getting a vaccine. You know, this so-called race towards who gets the vaccine first, and then the political arguments about, you know, do we share our vaccine? You know, do we let some other people have some? And, you know, you've only got to have a look at Israel and Palestine, and the fact that, you know, Israel was vaccinating, you know, all of the people that live there. They weren't, they were only vaccinating Palestinians that go into Israel to work. So it's that level, but also I think more the comparisons might be interesting in the long term, and I will round up now in terms of what will happen to COVID vaccines and treatments 2, 3, 4, 5 years down the line. That's where we're really going to see a difference in inequality. And when I think about the way that HIV is managed and treated in a world where women, children, sex workers, displaced people, people in low-income countries, the people that I work with in Chiapas still have no access. They have no access to PEP. They have no access to PrEP. They have no access to ART, and that is pharmaceutical and political. You know, they're still at a stage. In education, in prevention, and lack of access that perhaps the UK and parts of the States were in the late 1990s. That's really problematic, and that's something that really pisses me off quite a lot. And the final thing, when I agreed to do this as well, I kind of did a bit of a survey around my male gay friends who were around in the 1980s, who lived through this. A lot of people who kind of couldn't bring themselves to watch It's a Sin because it was too close. They'd lived through it. And actually a lot of what they said when I asked them if they thought there was any comparisons from a lived point of view of being a gay man, is that the one thing that's missing from the COVID epidemic is the element of morality, stigma and shame that comes with the HIV epidemic. That is, they said there's no comparison in terms of the way that they're shamed as a community, because COVID impacts everybody and HIV does impact everybody, but was only seen as that. So yeah, be quiet now.
That's really that was really interesting. Thank you so much, Jack. And I think some of the points you raised, about intersectionality and the lived experiences and shame and stigmatization have been things, that I've been thinking about a lot as well. And I'm sure a lot of, I know like Billy emailed me about this as well. So yeah, thank you very much. I think I'll come back to questions at the end. So I will go to Billy now, if that's okay.
Yeah, sure. Hi. Okay, I'll try and not repeat good points that better people made before me. But yeah, I guess some context to how I've been thinking about this is from really disasters background, so not a kind of even a public health, let alone a kind of epidemiology or other background, and thinking about the impacts of, I guess, crises on populations, and in particular marginalized populations. In this case, I happen to be talking about gender and sexual minorities, but could be other groups as well. And to do that, in this case, I was interviewing people in the UK and in Brazil, and by people I mean LGBTIQ+ people, about their experiences of COVID-19, in particular lockdowns and the restrictions and so on. And yeah, so I'll say a little bit about that, and then maybe I'll say some thoughts I had about It's a Sin. So yeah, of course I found kind of key challenges that particular people faced, increased mental health challenges, social isolation. Jack was talking about access to particular trans healthcare was a major issue, among others as well, and perhaps also things like particular employment or industries, employment sectors being hit harder than others, and who works in those sectors. So those discussions also apply to, precarious workers and people of particular ethnic backgrounds working in the gig economy and so on, but also with LGBT+ people working in certain sectors like nightlife and cultural or entertainment and others. And that also has had an impact on queer spaces, so where people feel affirmed and safe and free to express themselves, being disrupted. But I mean, Jack pointed to it as well, but I don't just want to sort of give a story of queer people are vulnerable, I suppose, because there's also been incredible stories of mutual aid and peer support groups and either emergent or pre-existing that have really filled critical gaps in official or governmental responses. And that's really important. And I think some of those experiences and some of those capacities come through lived experiences of marginalization. So having to do that before, because there were already these gaps in systems. And, you know, I'm just conscious that from my research, that's as big a story as people being impacted negatively. And I guess the other point is just the incredible diversity within kind of queer populations. And I'm going to keep saying LGBTIQ+ and calling them a community and all of these things, and we all do. But actually, in many ways, there's not much connection between many people in those groups, and the intersectionality and other factors maybe perhaps shape people's lives more importantly than just being queer for many people. And of course, we know there are inequalities within queer populations. You know, cis white gay men aren't far away from cis white straight men in terms of privilege, right? So it's very different to certain others. And that's certainly something that I found through the interviews that I conducted, and some of the unique challenges that particular people faced, whether that's sort of broader categories like trans and non-binary people, or more specific characteristics intersecting. So an older trans man with a disability, for example, was one of the hardest stories I've ever listened to. And that's not poor me, that's, you know, poor people who are marginalized by our stupid systems. So anyway, so I feel like that those are important points to make, and Jack was pointing to it as well, but something I've really wanted to highlight is that diversity within queer populations, but also in reporting on my work, but also the inequalities that come with that, and particularly in a Brazilian context more than a UK context as well. There seems to be, you know, segments of Brazilian queer populations that can't even join a Zoom interview because of access that they have to or don't have to technologies. No one in the UK had that issue, right? So that's a very broad statement, but that's a starting point to think about why do these biases in participation exist. There are many reasons, but I think one of them is kind of inequalities. And the result of that is, in my Brazilian sample, most of them are cisgendered gay men. Whereas in the UK, more than half of my participants are genderqueer or trans or non-binary. So, I mean, there are other things there, like which connections do I have, which networks am I, you know, drawing from, and so on. And that's far limited in Brazil. But I think there's something to say there. And I guess thinking about trying to link some of this to what I thought when I was watching It's a Sin. Something that I thought was just really obviously the same, or similar at least, is just that the experiences of the virus or any disaster or crisis really just reflect the pre-existing marginalization and social and economic inequalities that are already there. And when I say they're already there, they're not there inherently, they're not there by magic. We, as in policymakers, societies, governments, whatever, we make these, right? And that's clear in both. It's not the case that, you know, certain parts of the population are just inherently going to be more, you know, prone to mental health challenges because they're born that way. It's because we exclude them from structures, we isolate them socially, and so on. And that, I think, was really clear in both It's a Sin, if I take that as my knowledge about the HIV crisis, but broadly, but particularly in COVID-19 as well. And we also see how then their government responses and healthcare responses, whatever it may be, reproduce inequalities and exacerbate that marginalization is already there. And, you know, you could talk about things like the stigma of societies and so on with HIV, in which we saw in It's a Sin, meaning that, you know, provision of particular services is not provided, is not there for parts of populations, and that's a choice again. And in COVID-19, some examples, like there are reports in Latin America of basically assuming people are cisgender or heterosexual is a starting point for most policies in probably all fields, but especially in disaster management in terms of my knowledge. And so things like, I guess, aid distribution or quarantine rules or whatever it may be being delivered within those parameters reproduces the inequalities that already exist. So in parts of Latin America, quarantine rules were that you could go and shop on alternate days based on if you were male or female. So that increases violence, the risk of violence, discrimination, even confusion for people who aren't sure or don't fit that binary. The reports in the Philippines of same-sex couples not being given food aid because the food rations or food supplies, because the aid was delivered based on the government's views on what a family was, which did not include non-heterosexual partnerships. And in the UK, we've seen things as well, and Jack spoke a lot about the access to gender identity clinics and so on. So this is a gap that already exists. And then I'm going to use the word again, but by choice, as in not to communicate to patients that their care was going to be stopped, which I heard reports of from various people as well, is exacerbating the things like gender dysphoria, mental health, isolation, and so on, at a time when people are already anxious and you know, have reduced access to their support networks. So again, the idea that, yeah, choices we make in societies build that marginalization, and then policies that have a particular framing worsen those circumstances. The other, I guess the last point I'll say about, I was thinking about It's a Sin, which I touched on already, but through my interviews, really the kind of stories of, I guess, community and peer support groups and so on was really kind of clear in my research, but I think also applied to It's a Sin. So we saw groups of people in It's a Sin. The people who were supporting each other were other people going through that crisis. So in this case, largely other cis gay men, but also the one straight female character, Jill. I mean, Jill is the best thing in the show. Like, I will not accept any other argument about that. So you know, she's fantastic, but there should be more diversity. I agree. But yeah, so that kind of mutual support, they were the ones going to protests, and even during COVID in the UK, who turned up to the protests in the streets following the proposed changes to gender recognition and use of bathrooms and so on, predominantly really vulnerable transgender people and other queer people, right? So the idea that, yeah, people come together to support each other and there's kind of mutual aid and so on, I think was really evident in both cases. And a key recommendation from my research is that we need to better match those kind of groups with government responses. Government and public health organizations should have, let's say, liaison people or connections to these organizations and community groups, and should, you know, probably just give them more money as well. But yeah, better matching of that. If there are groups that are already doing really great work, let's support them to keep building that capacity, as well as acknowledging that there is a need in the first place. But yeah, queer people are often good at helping themselves. So give them money. Give them money. Can anyone here give them money? No? I'm talking to the wrong crowd. Okay, I'll finish there, because that's more than, what was I, 5 minutes? Yeah,